Okay, so today we are going to talk about the difference between goals in the educational space, which is essentially the school-based physical therapy, and goals in the medical model of physical therapy, which is essentially like outpatient physical therapy. First, we're going to talk about educational goals and how educational goals are different. And then after that, we're going to talk about medical model goals. The educational goals are essentially goals that would be functional in a kid's school environment. So you're going to look at the school environment. So opening and closing doors, stairs, playground. You're going to look at things that are really like class specific. In music class, they might have risers, which are kind of like stairs, but a little bit different. Keeping pace with peers. You're going to look at toileting, the big one for PTs in the school-based environment. Those are kind of the big things. Really, you're going to look at environmental-based things. Then you might have specific things like positioning for kiddos. You might have like a collaborative education goal. You might have an endurance goal. All of these things are going to be specific to the kid's educational environment. So an endurance goal would be maybe like sitting in a chair if the kiddo has a really weak core and they're not able to sit still for 5 to 10 minutes, but it's not a sensory component. They're not just getting out. They're basically just like slumped over in their chair and they're not able to essentially hold their weight against gravity, hold their posture against gravity. These could be like independence goals, wheelchair mobility, using a gait trainer, using a stander maybe to participate in academic work. We've got a bunch of ideas essentially for education goals. Let's head over to the medical model goal and talk about some different ideas for the medical model as far as goals go. So the biggest thing there is going to be gross motor milestones, things like rolling, walking, throwing, and catching, things that are specific to more of like the quality of the motion overall is really what you're going to look like there. I got a little wild on my educational goals. Other things that you can look at in the medical model is more specificity of the actual movement. In the school, you're looking more at function. So you're over here, for example, on the stairs, you're looking at function in the school environment, where over here in the medical model, you're looking for quality. And so if in the school-based, you're looking at safety. So like functional or safety, they could be at a reciprocal gait pattern, and this would be okay as long as they were both functional and safe. But over here in the medical model, you're looking at quality, which also means kind of optimal movement. And optimal movement is the best a movement can be. So you'd want it to be like a reciprocal gait pattern, 1 foot on each stair, no handrail. You would want it to be kind of in like, that 70 to 90% rate of peers. So you want them to do it well. You don't want them to just be able to do it. You want them to be able to do it well. Let's talk about what a medical model goal would be. So what that goal is going to look like, it's going to be a gross motor milestones. It's going to have kind of the components, the who, what skill, how much support, how accurate, and by when. So whether this is in the medical model or the educational model, you really do want all of these components to be together. So in the medical model, you would have, say you want to overall have a goal of a kiddo being able to get up off the floor and walk to a preferred toy. So you want them to be able to do it independently. We'll just call this little boy Joey, for example. Joey is who, what skill is transition from sitting to standing without, or that's technically the without in the medical world, without using his hands 3 out of 4 times within 3 months. So depending on Joey's level of independence right now, 3 months might seem like a long time, or 3 months might seem quick. So essentially, who, Joey, what skill? Transitioning from sitting to standing without using his hands. How much support? Technically, because I said without using his hands, it's kind of inferred that it's independent. So essentially there'd be like 0 support. Accuracy, 3 out of 4 times, and by when? Within 3 months. So just to compare that to kind of the same skill that is school-based would be Joey will transition from circle time to his desk using a sit to stand transition without upper extremity support 3 out of 4 times. So in a school-based setting, you're still going to use Joey. You need to make it educationally relevant. The activity needs to include both what skill and how is that skill educationally relevant. So by saying that he's going to go from circle time to his desk, that makes this a very specific transition. And you could also say then transition from sitting to standing in order to go from circle time to his desk without using his hands 3 out of 4 times. The reason why I didn't include the within 3 months was because typically at the top, there's going to be these dates, and this is going to be the IEP meeting date, typically a day or 2 forward from that, to -1 day from like 365 of the IEP meeting date. But the biggest thing for here is when you go up here to the goal stuff down here, it's going to be who, what skill plus educationally relevant. So what educationally relevant skill, how much support, is it accurate, and by when. And the other part of the thing that you really want to consider with a educational goal versus a medical model goal is it's okay if Joey only works on this with you in the clinic and then also has a home exercise program that is going to address the impairments, and you teach kind of some strategies to the parents to help them reiterate that. In the school district, you really want to make sure that the goals that you are making are collaborative with other professionals, including and specifically with the teacher. You want to pick things that the kid is going to do throughout their day. So you don't want to pick just something that you're solely responsible for, because what we know through research is essentially that the child needs so many more opportunities in order to make growth. And if they're only seeing you once a week for 30 minutes, then they're not going to make appropriate amounts of growth. It's really better for you to teach everyone how to fish. Fishing equals best for Joey and progress for Joey. Whereas if you just do it once a week, it's not going to be enough. So let's kind of do one more example, because I do feel like this is really helpful for people. Joey will hop on 1 foot without upper extremity support times 10 in a row in 3 out of 4 trials within 6 months. So a lot of times in outpatient pediatrics, the plan of cares are made for 6 months. And so sometimes the goals are shorter than 6 months. So they would be short-term goals, and sometimes they're just right at 6 months, long-term goals. So again, you're going to see Joey, who, what activity, hop on 1 foot, level of support without upper extremity, independent. If he did need support, it would be like hop on 1 foot with upper extremity support from adult, or with upper extremity support from a stable surface. How many, or what's the accuracy? You want it 10 times in a row in 3 out of 4 trials. You could also just write 10 times in a row in 1 out of 4 trials. It doesn't always have to be like that 75-80%, but what this shows is that there is a high repetition of improvement for the kiddo. And then your time frame, which is within 6 months. So how to make this more educational? Say that the underlying impairment is that Joey has weakness in his legs. And while in outpatient orthopedics, outpatient pediatrics, he's working on hopping on 1 foot. While that is an impairment, it's not necessarily an impairment that is educationally relevant. But what you may see is that because Joey has a hard time activating his plantar flexors in order to hop and get foot clearance, he also shows an increased incidence of tripping when he's walking in line with his peers, or he's not able to keep up with his peers, and so he's kind of constantly getting bumped into by the person behind him, or he's getting kind of left behind if he's at the end of the line of friends walking down the hallway. We want to pick something that he does throughout his day. So in that example, I would say we're going to work on obviously increasing his gait cycle, improving his lower extremity strength, increasing his power and his endurance in his lower legs. But the one activity that we can measure over time with multiple individuals and have a collaborative goal with is essentially walking in line with his peers. That works on balance, it works on focus, it works on proprioception, it works on strength, it works on power, it works on all these things. Joey will maintain the same pace as his peers while walking in the hallway without verbal cues from teacher or complaints from peers 1 out of 5 times, let's say, per day. So let's say that this is actually a really big area of struggle for Joey. He's constantly getting kind of bumped and pushed from his peers behind him. They get mad at him. They're like, why can't you walk as fast as me? I don't understand it. And the teacher's constantly throughout the day, every single time they leave the classroom, telling Joey, keep up with your peers, focus on where you're going, walk faster, things like that. And so this is a really big area of struggle. And we know that Joey can't hop on one foot without upper extremity support 10 times in a row. So we know that the plantar flexion is an issue for him. So we're going to make a realistic goal. Joey to maintain the pace as his peers. We want him to work on that. That's the activity we're really working on. How is it educational? While walking in the hallway. What level of support? We want him to be able to do it without verbal cues from his teacher and also complaints from peers. So that's kind of, this is like his social cues and verbal cues from kind of the expert, which is the teacher. But we know this is a really big area of struggle for him. So we want to make a really realistic goal so we can show that we're making progress and not that he's just constantly struggling. We really want to make bite-sized goals that we can focus on because we know gait is a complicated activity and we know that when we add in his peers, we're already challenging this task. We're not asking Joey to maintain the same pace as a one-on-one person walking down the hall with him with no one else in the hallway. We're asking him to walk at the same pace as his peers in close proximity while walking down a likely crowded hallway with other classmates and a lot going on to visually distract him. So that's how I would take something that's more medical, where here in this medical model, we're looking at kind of the quality. Here's the quality of the motion. We want it 10 times in a row. We're working kind of on those impairments of balance, strength, gross motor milestones there. Where here down in the educational model, we're really working on all those impairments, but we're going to do that in our treatment sessions and through cueing and through practice and carryover from multiple experts or teachers and paraeducators, and maybe make some adaptations. Maybe some of our treatment for Joey includes like placing him in the front of a line so he doesn't get like visual confusion, because like little kids' heads bop up and down, and sometimes that can be visually confusing if you have any visual impairments. It also allows him to set his pace versus having to kind of go faster, slow down, depending on someone else's pace, and things like that we could do for interventions. And then as we collect data, we want to kind of challenge his carryover of these new skills, place him in the middle, make it a little bit more challenging, and see how he's doing in a more natural environment, because, you know, it's not within his least restrictive environment for him always to be in the front of the line. We may have to make that modification or accommodation in the beginning, but at the end, when he's kind of getting better at that, we want to be able to have the line leader go back to being that like class job for the day, where you change it based on whoever is in that position and not because of something that is an accommodation or modification. Not saying that that it couldn't be that. You could have an accommodation modification where a kid was the line leader every single day for years, no matter what class they're in. If that's what's best for the student, absolutely. But our end goal is really to get him or her back into kind of a typical peer rotation style, where some kids are at the front of the line, some kids are at the back of the line, some kids are in the middle of the line, and their impairments are not necessarily influencing where they're at. They're more adaptable based on wherever they kind of end up. So I hope that you found this helpful as far as different ways to break these goals down and some different ideas and examples of different goals between the medical model and the school-based model. Each physical therapist is going to have like their own slight preference on how they write goals, but as long as you have these components, you can absolutely change the different style of wording and things like that. Again, make sure that you subscribe to the channel. It helps so much because it allows other therapists and parents to find these videos and give them a little bit more insight into how physical therapists think. And it really, at the end of the day, helps the kiddos benefit, because the more knowledge we have, the more empowered we have. And I honestly appreciate every single subscription, or subscriber. So again, this is Dr. Lauren Baker, physical therapist. I hope you have an amazing day, and thanks for joining me.